I had the pleasure to meet you, Greg, but also you, Laura Case, recently at a very impressive social touch conference. And you introduced me to this group, and you invited me to share maybe a brief overview on the field that I have been following in the last 2 decades, which is the fascia research field. So in the following minutes, I will give a selective overview of some of the more recent developments of what has shifted, where the main focus is, and how manual therapy may have an overlap with our research field. And then I hope at the end I can promise some interesting debates. And I'm very open in acknowledging where our weaknesses in this field are, but also our challenges and our possible contributions in sharing our insights and questions with other fields. So fascia is not a new discovery, of course. It can hardly be overlooked in anatomical dissections because it's almost everywhere. But it has been treated similar like a wrapping of a human gift that you remove and then you can see what's underneath much clearer in most of the mainstream anatomical dissections in the last 400 years. So as almost everywhere, you remove the fascia around the muscles, around the organs, as if it's not really needed to understand the organ, and then you dissect it. Now that shift, that fascia is more than a wrapping, had been indicated before by some pioneers like Andrew Taylor Still, the founder of osteopathy, or Dr. Ida Rolf, the founder of Rolfing, but it has not arrived in mainstream Western medicine. And that has basically shifted, particularly since the 2007 first Fascia Research Congress that was held at Harvard Medical School Conference Center. And there was subsequently a science paper on this newly developing field, which is now called fascia research. There had been early criticism, why don't you call it applied connective tissue research? But since that first science paper, and also because connective tissue research is already an established field in which fascia plays only a minor component of the attention, most people are relating to that now as fascia. One of the keynote speakers at the 2007 Congress was Donald Ingber, who in the previous years had been very successful to convince most of his cell biology colleagues of his concept of tensegrity-inspired biomechanics within a single cells. So he showed you can predict the force transmission within single cells, usually quite accurately by assuming that the microtubules and the microfilaments interact with each other in a similar, not identical manner than is shown here in this tensegrity column, for example. And he inspired the audience at the 2007 Congress to widen the established concept of fascia as it still is defined in the terminology anatomical, where only few fragmented tissues are considered as proper fascia, and they are usually not interconnected with each other. And to use a more functional concept in which all collagenous fibrous connective tissues, whether they constitute joint capsules or whether they are the epimysium around the muscles, or whether they are the intramuscular connective tissues or ligaments or organ capsules, that they could all be considered to be part of a body-wide interconnected attention transmitting system. And that has been the main emphasis since 2007 to study tension or force transmission in a mechanical analysis by this wider inclusion of fascial tissues. And one of the most famous and influential concepts that since then, but already before, has been influencing the thinking in almost any kind of yoga teacher training has been the concept of myofascial force transmission lines called anatomy trains or myofascial meridians by my Rafa colleague Thomas Myers. And he emphasized that there are certain linear myofascial transmission lines in which if you pull, for example, on the plantar fascia, the tension could have an influence all the way up to the galea aponeurotica, which is the dense fascia covering the skull here. In the past, that was not based much on quantitative measurements, but more on plausible thinking and anecdotal reference by people who applied it. Nevertheless, Tom Myers was able to dissect the geometrical or topographic continuity of these proposed tension transmission lines out of cadaver dissections. And many people took that as evidence that really this is, if they are topographically continuous, that then Tom Myers already had proven that this is a preferred force transmission line. But that, of course, is not a logical assumption because it could also prove how skilled the dissector is. So if you are very skilled, you can cut out almost any continuity in any hypothetical spiral in the human body if you discard everything else. So based on now a more quantitative focus and less anecdotal and less experiential focus, my colleague Jan Wilke has done a systematic overview on which of these force transmission lines really have a solid anatomical evidence. Now, he showed that the majority of the force transmission lines, there is anatomical measurements that support it, but not all. For example, the superficial backline here on the upper left, there is lots of evidence and probably more than 40 studies, probably so anywhere between 30 and 100 studies, anatomical studies have focused on force transmission. For example, at the very important sacrotuberous ligament. Many studies have showed that many fibers of the biceps femoris, one of the most important hamstring muscles, many of the fibers do not attach at the ischial tuberosity, but they continue even in a sliding manner into the sacrotuberous ligament. And then the sacrotuberous ligament is connected with one of the layers of the thoracolumbar fascia. And then, of course, you can ask yourself, is the name sacrotuberous ligament justified if it also serves as a tendon? And so you could call it a tendoligament. Or you could look for Golgi tendon organs in this former ligament there. So these are just some examples of the many studies that Jan Wilke has shown. Now, he also showed, for example, that my favorite line, the spiral line, yes, there is sufficient anatomical evidence above the iliac crest, but not below the iliac crest. And then you have the very nice challenge, how do you include the spiral line into your yoga teacher training if it doesn't have evidence below the iliac crest? Because for pedagogical reasons, it's of course more appealing if the legs are included and if it's a whole body spiral there. And most of the yoga teacher training, they have not cut the lower portion out for understandable reasons there. Now, this is mechanical force transmission in a cadaver analysis. It doesn't measure how your skeletal muscle fibers may co-contract. in a similar neurologically mediated manner that when you roll your eyes to the right and to the left, that the tonicity of your upper neck muscles may be influenced. And you don't need a passive fascial connection for all that. That could be a neuromuscular coordination, for example, in the somatomotor cortex. So this is not looking at co-activation of muscle fiber groups. It's looking at passive force transmission. If in the neutral position on a cadaver, you pull on a sheet of fascia, in which direction is it spreading and in which direction is it not spreading? So this has been very influential, for example, for the importance of the thoracolumbar fascia and how tensions or adhesions there could be influencing or could be influenced themselves by, for example, therapeutic applications in other regions of the body, whether that's done with stretching or with foam rolling or with other active interventions, for example. One of the most influential researchers looking at the role of fascial morphological changes associated, for example, with low back pain has been coming from Helen Laurgever. And she had shown previously that the two membranous layers of the thoracolumbar fascia that belongs to the superficial backline that I just showed before, that in healthy people, they have an easy horizontal shearing mobility to each other. So if you go in forward bending, there is a clear horizontal displacement between them. And in chronic low back pain, they seem to be more adhered. So in the same skeletal forward movement, your shirt is moving less on your underwear underneath, if you want to use that image of horizontal displacement of one layer in relationship to another. And then, of course, she was asking what could be influencing the reduced shearing mobility in the thoracolumbar fascia. And she did this brilliant animal experiment in which in one group of animals under anesthesia, she did a injury in the thoracolumbar fascia. And then, of course, you wait for the injury to heal. And then with her ultrasound analysis, similar to humans, she looked how is the shearing mobility. And of course, she could reconfirm in injured fascia afterwards, the free shearing is inhibited significantly. So that could mean that for some of the human people where the thoracolumbar fascia has reduced shearing mobility, it could be the after effect of an acute tearing injury, for example, in the thoracolumbar fascia. So that would be one scenario. But she also explored a different scenario in which you don't have any fascial injury, you only have a lack of free mobility. So in these groups of animals, and maybe some of your neighbors and the people that you treat will remind you of them, she restricted the range of motion, so where she had a hobble band from one of the hind limbs to the trunk, and then on that side of the body, they could only move with small steps and they could never stretch during an average day. So movement restriction for several weeks. And then she analyzed the same shearing ability with ultrasound, and you see it comes to the same degree of adhesiveness or reduced mobility. So both of these factors could be, that's our consideration, if we have similar conditions in humans, could be underlying the reduced sliding ability of the thoracolumbar fascia that she had shown before exists in chronic low back pain patients. Very interesting for me when she had a third group of animals where in addition to a previous fascial injury, they also get a movement restriction, then you had twice as much. Now, that is for me a brilliant research, because for us manual therapists, but also movement therapists, I think it's a strong invitation if you're treating somebody with a shearing mobility restriction, or let's say somebody with chronic low back pain, where Helen Lorschewer's research indicates many, not all of them, have that movement restriction in the thoracolumbar fascia. If you then only work with the wound healing and scarring that happens there with your hands as an after effect of an acute fascial injury, you are only and not educating your clients to move differently during their average week, so that when they untie their shoes, they don't need to sit down every time, that they can do it standing, reaching down, or walking with wider steps. So it makes sense that you treat both of these contributors and not only one. So for me, that is a strong argument that manual therapy alone and also movement therapy alone are usually not as potent as if you include both of these additive and contributing factors, at least in animal research. And of course, we need to do similar studies with humans, but that has not yet been done. Now, the question is, what are influencing, what could be happening in this in the reduced shearing mobility? And you see here two ultrasound images. And ultrasound has become, I can show you one of these modern fancy ultrasound images, because it's getting, so they have now handheld ultrasound images, machines, the Clarius, for example. You don't need a cable, it projects to your smartphone. And they are quite handy, but they also have their challenges. But where they are usually quite good is to measure the thickness of the epimysium. The epimysium is the usually thin fascial membrane on the outside of a muscle. And here on the upper image, you see, if I would do an ultrasound imaging, I show it on my video, on the sternocleidomastoid muscle. And that is often a muscle where you can palpate or see how tight it is. And for example, in some people with torticollis, it seems to be much more stiff on one side than on the other side. And then you can ask yourself, is the stiffness coming from the envelope, or is it coming from the muscle meat underneath the envelope, or from both? And the ultrasound could give you an indication, because it's not measuring the stiffness, but potential thickness changes. And you see in the upper picture, the light gray zone would be the fascial envelope around the muscle, and underneath in dark gray would be the muscle meat of the sternocleidomuscle. Now, in some people, it could be somebody with torticollis, it could be a professional violinist who has to hold his violin for 8 hours a day on the left side, but not on the right side. Then you could use your fingers, but I would think also the ultrasound head, to see, do you have any morphological change in the envelope and or in the muscle meat underneath the envelope. And you see in some of them, the envelope is twice as thick. It is 3 millimeters, 4 millimeters thick, and that is way above the thickness somewhere else. So that means you have a fibrosis. So the light gray is usually collagen type 1. You don't have a guarantee, but that's the high likelihood here. And that doesn't go there. So the body needs several weeks to create that in collagen synthesis. And that could be a contributing factor to some of the stiffness associated fascial pathological changes that you have there. But now, in recent years, in our field, that was not very prominent 15 or 20 years, but in the last 5 years, the emphasis has shifted to hyaluronan, and it may express to something like in the middle field, where the total envelope is thicker, but not the collagenous fibrotic two layers. It's the ground substance between the two membranous layers. And this ground substance, we have indications, but it's not yet totally proven, is hyaluronan as a lubricant in a viscous, in a more denser, less lubricating condition. And then the total envelope is also thicker, but it's not due to an increase of collagen fibers. It's due to a viscous ground substance layer between the two fibrous membrane layers. And it would be for the future helpful if we can distinguish whether you have a fibrosis or whether you have what's now called densification in the ground substance, because the ground substance can change more rapidly in a negative but also in a positive direction. A fibrosis does not get into existence and does not disappear in 2, 3 days. It's usually a matter of several weeks. But the ground substance you can change in a couple of hours or in a couple of days. And there comes the, I think, spectacular new discovery of a resident connective tissue cell by Carla Stecco at the University of Padua. She discovered these round cells. I have seen many of them, but I couldn't make sense out of them because the normal fibroblasts are longitudinal and they are more like a spindle one. And she discovered that these round cells, they usually come in groups and they are usually located at the transition between loose connective tissue here in gray and more membranous connective tissue here in pink. And she found out that these round cells seem to be specialized not on producing collagen fibers, but on producing hyaluronan as a lubricating substance. And she gave these cells the new name fasciacytes, and they have been reconfirmed now. And they seem to be responsible for creating hyaluronan. And she showed that the tissues have very different quantity of hyaluronan. Those tissues where you have a lot of shearing in the immediate neighborhood, you have a high expression of hyaluronan, for example, below the retinaculum on the wrist, you have a very high hyaluronan, and on other regions where in the immediate neighborhood you have not much shearing motion, for example, the epimysium of the deltoid or the trapezius muscle, they move very little in an average person in relationship to the muscle fibers underneath. So there you need less lubrication and you also find less hyaluronan. So that seems to be regulated by these fasciacytes. Recently, she showed that shockwave therapy, but also endocannabinoid stimulation, both influence these fasciacytes to produce more lubricating hyaluronan in subsequent minutes and hours. So that could be possibly one of the explanations if you have beneficial effects by shockwave therapy or by endocannabinoid on pain modulation. Maybe it's also not only the pain signaling and the neurological effects that the endocannabinoids could have, like TBC oil ingestion, but it could be also less friction due to a better lubrication in the mechanical morphological conditions of the fascial tissues. Now her brother, Antonio Stecco, is looking at the biochemistry of hyaluronan and how the aggregation, whether it comes in a large molecular aggregation form or in a very small aggregation form, has a very big influence. So, as you can see on that chart here, the aggregated form of hyaluronan comes together with a more viscous, so more stiff and less lubricating condition, but also you have more unbound water because a lot of the connective tissue water, connective tissue, even the tendons, consist out of more than 60% water. And some of the water is attached to the hydrophilic hyaluronan, and some of the water is unbound water. And in a healthy body, you want to have approximately 50% of the water not in an unbound condition, like in an edema. You want it in a bound condition due to proximity to hydrophilic hyaluronan. But if the hyaluronan is in a huge aggregation form, in which it does a lot of binding with itself, then the water binding is decreased. If you then break down the supermolecule-sized aggregated hyaluronan into smaller fragments, and you can do that by mechanical friction, you can do it by heat application, or you can do it by injection, for example, of hyaluronidase as an enzyme that breaks down the aggregated hyaluronan. Then you have more the small fragmented hyaluronan that has more water binding, but is also in danger of possibly being associated with pro-inflammatory condition. But of course, you have less friction between, so you have a more lubricating factor included into that. Now, the question is, does massage offer a possibility to break down the aggregated and the viscous hyaluronan into the more lubricating way? And there has been one study so far with T1 row MRI imaging. That is very expensive and not many hospitals have that, where you're not only looking at the water content, but whether you have bound water versus unbound water. And in the upper row, you see a tennis elbow condition in which the unbound water, you could say edema-like water, is marked in red by this kind of T1 row MRI imaging. And then Antonio Stecco did a few minutes of vigorous fascial manipulation, and then they did the MRI imaging again, and you see the unbound water has become as bound in light green as in other regions of the lower arm. So that is a moderate indication that you can change with normal massage forces in a few minutes, at least in some conditions, the hyaluronan and its related water binding in the connective tissue. It has not yet started, but we expect it to come out in a couple of months. A Czech company has licensed a lubricating hyaluronan substance that the medical doctors will inject in the future in some cases of low back pain. Not all low back pain is associated with fascial changes, and even if it is, it's not clear if that's a causal contributing factor or whether it's just a non-causal subsequent expression due to lack of movement. but most people agree, whether it's cause or effect or both, it's a helpful factor to increase the sliding again, even if it's only is to increase proprioception. If the two layers of the lower dorsal of the thoracolumbar fascia are glued together, that they always move together, as I show on the video, if there is a Ruffini receptor in between them, it will be very hard for them to give you feedback about your lower back being in lordosis or kyphosis or anything in between if they are moving together. But if they are starting to move again, then at least it's easier for you to have a non-pain associated proprioceptive feedback happening there. And most people would assume that is beneficial. So there will be a synthetic small molecular sized fascia gel, and they tested it not only in animals, they also did a randomized clinical trial that I have seen. It's not yet published, but they needed that for the licensing, in which they compared the not only the sliding of the thoracolumbar fascia in low back pain patients, but also their pain expression in the group who got the fascia injection into the thoracolumbar fascia with ultrasound guidance, of course, as opposed to those who got a placebo injection. So my prediction is fascia will become more famous now because the medical doctors can earn money with it, and that was not the case in the past. Whether it's necessary, whether it's beneficial to replace the hyaluronan that should normally be created by a healthy movement. So if you are rolling on the floor with your kids, if you are swinging your legs during the week, the prediction is you would not need to substitute the lubricating hyaluronan from the outside. Similar like your neighbor who gets hyaluronan injections into her face, and she has a better water binding and younger expression. Instead of doing so, she could do laughing therapy or smiling every day in order to increase the hyaluronan by more natural means. Nobody has done a study for that, but we know the fasciacytes, they produce more hyaluronan if you have more stretch stimulation as opposed to immobility. So this is definitely a trend that will be coming. And now there is a shift happening because in the image I showed you before, several years ago, we wanted to decide if it is a fibrosis, for example, like in frozen shoulder, and then hyaluronan is not involved. It's a proliferation of collagen type 1 fibers, or in Dupuytren contracture in the Viking hand here, or is it densification in which you don't have fibrosis, but you have the densification of the ground substance due to the higher aggregation form of hyaluronan. So there are two different pathologies. But now there is a strong model that many, not all, but many of the fibrotic conditions are the subsequent development of a previous densification. And if that is true, there are some indications, then you could possibly prevent frozen shoulder before it gets into a fibrotic state and before you even have pain sensations there, just by the sense of the stickiness and the fibrosis and the water binding in the ground substance before you get the fibrotic changes in the fascial expression. That is now a new proposition, and it seems to make a lot of sense for many, but not all of the fibrotic decisions, even in Dupuytren contracture. They now see that there are some ground substance and lymphatic changes before you have the fibrosis. So that is now a more encompassing functional model. In the last 2 years, my eyes and many people also in the fascia field have been opened by the group around Michael Kjær in Copenhagen, who are kind of the world leaders or among the world leaders in tendon research and how that is affected by mechanical loading, for example. And of course, we include tendon as one, or tendon sheets also, as part of the body-wide fascial network. And they have shown, to my surprise, that in people with chronic tendinopathy, for example, tennis elbow, the circadian rhythms seem to be disturbed. So in a healthy circadian rhythm, you should have strong cortisol expression in the morning and less in the evening. And with melatonin, you should have the opposite. In people with tendinopathy, that is disturbed. And they are not clear whether this disturbance in the circadian rhythm is cause or effect or both of the pathology in the tendon tissues. But now more and more people look at how is collagen fabricated in the body in a circadian perspective. And it's clear that the collagen inside of the cell, usually in the endoplasmatic reticulum, is mainly produced during night times, not during daytimes. So if you don't have sufficient sleep then the production of collagen material inside of the cell may not be optimal. However, the expression of collagen fibers outside of the cell happens during daytimes. And as you can see in the middle pictures, you have three groups of collagen fibers: small ones, very large ones, and medium-sized ones. And they are fabricated at different times of the day. So you see, the small fibers should be done in the early morning hours, and the big ones should be done in the afternoon. Now, if your circadian rhythm is disturbed, be it due to changes in cortisol or melatonin or light exposure or chronic inflammation, then it makes sense that the timing of when things are created, so it's similar like on a healthy farm, things need to be done, but they should not be done at the same time. And similar like a good cook, you don't put everything in the oven at ridiculous times or on random times. You put them in the right order. And if that order is disturbed because nobody has a watch orientation, that could be a strong contributing factor. So now people are suggesting not only with tendinopathies, but also with adolescent idiopathic scoliosis, where we know the collagen and the bone expression is influenced, and we know that not the absolute amount of melatonin, but the melatonin signaling is disturbed in these puberty-associated scoliotic girls usually. Now people are looking, maybe we should honor more clearly the contribution of these circadian rhythms. So let me continue towards the end. Oh yeah, Greg, there you are.
Robert, maybe 2 or 3 more minutes.
Okay, great. So let me pick and choose because I don't want the discussion to finish there. So I'll jump here. This is a very recent publication pointing at the lower zone of the subcutaneous connective tissue under the skin. So in the subcutaneous connective tissue, you have a superficial adipose layer, you usually have a membranous layer called superficial fascia, and then you have a deep adipose tissue layer. And this new gene analysis says the lower deep adipose tissue layer has a more pro-inflammatory capacity, at least due to its gene expression. And that has been shifting now a lot of emphasis in manual therapies. not to apply only vertical pressure, but to move the skin in relationship to the fascia profunda underneath in order to possibly influence the lower adipose layer that seems to be more influenced by pro-inflammatory conditions. And the question is, can we influence inflammation with manual intervention? And one of the many studies, but I think one of the best, is from Larissa Sinharim, where she did a gentle myofascial release stimulation on the thoracolumbar fascia in mice and compared it with a placebo intervention. And she showed, yes, there is a clear anti-inflammatory response in the connective tissue that she has treated there. So let me come to a conclusion and say thank you to the whole team that I'm collaborating with, and I hope we have some interesting questions and comments.
Robert, thanks for a fascinating talk. It's great to see the story as you told it today. We have about 15 minutes for questions, so I'll open it up now. Either raise your hand physically or virtually. Francis. Francis, you're muted.
Thank you very much, Robert. A very balanced approach to understanding fascia. The stuff I'm interested in is the subcutaneous fascia, and particularly its innervation, its cutaneous innervation. As you know, many of us in this group are obsessed with this C-tactile afferent and its role in stress relief. But we just, I for one, have no idea what innervates the fascia, whether these low threshold C fibers are also in the fascia. So what can you tell us about the C-tactile afferent and its innervation potentially in the fascia?
I was hoping you could educate me on it. Some years ago, I erroneously assumed it's not only in the dermis, but also in the subcutaneous connective tissue layers there when I read into your literature. But now I'm not so sure. It seems to be mainly the tactile C fibers in the dermis. But the new discovery of Laura Case that there seem to be also some pressure receptors, possibly below the dermis, which respond to slow, steady, and stronger mechanical pressure, if I understand you correct. There, I would think that they are below the dermis, but the tactile C fibers seem to be in the dermis.
I also think they're in the epidermis, although we published a paper recently that they're coupled with hair follicles.
Yeah.
But the thing about the CT, its preferred response is gentle touch, not a higher force, which would presumably impact on some of the receptors, mechanoreceptors in the fascia. And a lot of deep massage, of course, is bypassing the response characteristics of CT, so they don't necessarily like a high force stimulus, but it's just maybe Laura can wade in here because she's done some work with Hawkan, I think, on this one.
What could be supportive is the new calculation by Carla Stecco and her team that the richness per square millimeters is much higher the closer you go to the body surface, and it gets poorer if you go deeper away from the skin in terms of fascial tissue. So the periost or the ligaments or the joint capsule has much less innervation density than the subcutaneous connective tissue or than the skin.
Okay, thank you.
Ruth, do you want to ask your question next?
Hi, Robert. How are you?
Thank you. Nice to see you.
And you. Thank you so much for your talk. As always, it's really informative. I appreciate it. Having been in the, I'm going to call fascia world since 25 years, a long time.
Yeah.
I think there is still a disconnect between what we think we do to fascia versus social touch, CT afferents, neurophysiological approach. I'd love to see an awful lot more of the marrying of these two concepts. But my questions are, what do you think, in the last slide particularly, you showed that myofascial release made a difference in an animal study. Do you think there is an equal amount or more or less fascial changes, otherwise stretching the fascia, versus perhaps CT afferents, the neurophysiological approach? Are we changing Pacini, Ruffini? Is it talking to the brain more? And even brain mapping in the homunculus. Do you have any idea what the direction could be?
I would love to. I'm not sure how, if you would exclude the tactile C fibers and only affect other layers underneath, how much of our beneficial effects may be left. I hope there would be some left. Yeah. But I don't want to bet on that.
Yeah.
Do you think it's more than half or?
I think I've always thought it's an interesting question. If, you know, your background is rolfing, so I would hope that we're making some proprioceptive changes in there and not necessarily stretching fascia. I think the language on that is a little bit inconclusive, never mind
Yeah,
perhaps the research, but I would hope there's proprioceptive changes in there from more firmer touch. But I certainly think the likes of myofascial release, for example, the Barnes approach, myofascial induction, I think has far more to do with the neurophysiological changes and a lot of contextual factors.
yeah.
And I don't think there's enough of that discussed in the world of fascia. I think we need to bring that into fascia research a lot more. I think it's sadly missing.
Maybe a partial answer are the stretch investigations of Helen Langevin that go without touch, in which he had animals do 10 minutes of yin
Yeah.
yoga inspired stretching. And
Yes.
they had a similar anti-fibrotic and anti-inflammatory effect compared with Larissa Sinhorim's manual treatment. So even without manual treatment and without stimulating the tactile C fibers, I don't think they were included in the stretch stimulation because it was static stretch.
Yeah.
So they would not be stimulated. You still had a beneficial effect there. So maybe
Yeah.
that's a
I
partial
agree.
answer.
I
Yeah,
agree. I know the study you're talking about. It's the one with the
yeah,
rat of the tail. Yeah.
yeah,
Yes, absolutely. I think there needs to be some pooling together of the information. I think it's totally valuable, and I'm very humbled at the amount of people here with the knowledge that they have. So
yeah,
I appreciate your
yeah.
time.
There has been some very intriguing work by Cherry Telly, an osteopath in Italy, on the focus of the attention of both the patient but also on the therapist, on the
Yes.
touch or away from it. And I think that would be a very beneficial direction because you want your touch to be more potent than their underwear is.
Yes.
And their
Yes.
underwear sometimes has the same magnitude of stimulation, but of course you don't pay as much perceptual attention to it.
Mhm.
So as his research has shown, the mindful attention of therapists, but also of the practitioners,
Yeah.
seem to have a potent contributing effect. And I would love to
Yes. Yeah,
continue.
I agree with that.
Yeah,
Yeah, totally agree with that. And that goes, for me, that leads us right into brain networks,
Mhm.
default mode network, for example. And I think there is so much more that we could learn. So
Mhm.
yes, thank you.
Mhm.
Robert, I had a question. Thank you for your talk. So I'm a physical therapist. I took STECO level 1 and level 2. So my question's coming from more of a clinical implication for the patient? Because literally yesterday I had a patient say, like, how long does this last? Right. So I was doing fascial manipulation. She had phenomenal response. But then her symptoms started to come back. And of course, every patient is different, you know, what we're treating, the longevity, the irritability. But my question to you is there any research out there showing the length of time, you know, that we're seeing some of these biomechanical changes in the hyaluron, and, you know, what are the clinical implications for that?
I can talk about the morphology, but how pain, of course, is not only dependent on the morphology. I don't need to tell you that. On the morphology, we have learned mostly from the Copenhagen group that the remodeling is much faster than we used to think. So for intramuscular connective tissue, the endomysium and the perimysium, that tends to get stiffer as we age, for example, the perimysium, and then our muscle spindles are not so sensitive. The remodeling at rest, not immediately after exercise, but at rest, usually is 14% per month. So it means after 7 months, most of the collagen inside of your muscle tissues is new. And whether that is fibrotic or not, that depends on how you have moved in the last 7 months. If you have been like the pigs in Helen Lorgever's study, where you walk with small steps and you don't move and you don't stretch, and you have very limited movement variety, then of course it will be more in a less free gliding condition. But if in the last 7 months, or even in the last 3 months, already 50% of the intramuscular collagen fibers are newly created following the tension application that you give them. For the tendon, unfortunately, it's much longer. And the worst tendon is the Achilles tendon. You have some fiber bundles in the Achilles tendon where the renewal rate is 100 years after skeletal maturity. But for most of the fascia, you could say 3 months, and you have already 50% of the fibers different, and then you have different conditions. So that would be my long answer.
So, if I may, first, thanks for including Dr. Langeman's work on thoracodorsal fascia, the thoracolumbar fascia. I know she measured that with ultrasound, but from a clinician's perspective, I'm a chiropractor. We have other myofascial therapists here as well. You know, is there any way for us to really objectively assess fascial shear, fascial adhesions from a practical perspective, you know, in clinical practice? And have there been any comparisons between those ultrasound studies that have been done and a clinician's ability to detect that manually?
Right. This is the major focus of my colleague Andreas Brandl. I love, most people have not seen his name, Andreas Brandl. He just did, he developed a more rapid ultrasound measurement system of the mobility of the thoracolumbar fascia that you can do with a portable ultrasound head in 3 minutes. But he measures the horizontal shearing of the thoracolumbar fascia at a certain portion of the lower back in relationship to the dermis. So it's more the adhesiveness between the dermis and the first layer of the membranous layer, and that's very different to Helen Lorgever. But we think it could be more practically relevant because when you do the Keebler fold, so the client lies on their belly and you lift the skin, and on some areas you cannot lift it so much. Then I think you are exploring the skin movability, and we are developing now apparatus to quantify that. You can use the classical adherometer, how much can you move a scar into 4 different directions, and you come up with an index. So the skin mobility could be associated with low back pain or other pathological adhesions, even in further deeper layers. So that is one direction.
Great. Thank you.
Hello, Robert. How are you?
Good.
Nice to see you.
Nice. Good, Terry.
Good. I haven't seen you for a while. I'll be back in Italy in October. I just in follow up to Matt's question, I can send you a link to, it's point specific, but we did do a pilot study with 100 patients looking pre and post treatment for only 30 seconds to a minute, where we measured the densification. So I think that that does encompass some of the examiner's ability to identify a point and then measure pre and post. That was correlated with a significant reduction in patient-reported pain.
Right.
So I can forward that to Matt.
That'd be great. Thank you.
And then also, my question was about the anatomical dissections that you mentioned. And I apologize for not knowing this already, but especially when you were talking about the spirals, do you know how many of those studies were done with fresh versus embalmed cadavers?
Most of them are formalin embedded, unfortunately.
Okay.
Yes.
Yeah.
And then, of course, the amount is limited, but not the directionality. And you would assume that the relative mobility is the same, but so everything is reduced, but to the same degree. That is the assumption. Yeah. Now some people are doing on living people. Also, Jan Wilke is doing that. Sergio Fonseca published a paper recently. So on living people, you stretch the latissimus dorsi and you see how much of that force in a resting condition is transmitted to the gluteus maximus, for example. So some of these have been added to the cadaver studies.
Okay, that was one thing I regretted doing with the interosseous membrane work we did with Joseph Morley, was we used embalmed tissue, and I really think it should be repeated with fresh.
Yeah. Of course, the water content is not the same in fresh, but it is more similar.
Okay, any other questions? We're at the top of the hour, so we're almost finished, but maybe a quick question if anyone has one last burning question.
Will the references be possible to get access to?
The whole talk is recorded, and we are posting that on the Neurons Matter YouTube channel.
Okay. Right.
You go out, it'll take us, probably a week or two to get it posted, but we will post it. And yeah, I was writing down those references as fast as possible myself, but it'll be online.
Thank you.
Yep. Thank you very much, Robert. Great talk. We appreciate it, and best wishes, everyone. Thanks for coming.
Thank you.
Thank you, Robert.
Mm.
Thank you.